Thank you, Professor Sarkis.
Thank you.
I haven't done anything yet. Thank you to the organizing committee for allowing me to come and talk to you today. I will be honest, yesterday at 12 o'clock when I was asked to come here, I was a little bit reluctant. It was extremely short notice. And I looked out of the window and I saw the snow falling. And I thought, really, this is actually a great idea. Let's go to the Mediterranean. So I'm here today and I'm glad I can talk to you about it's the future of aortic stenosis. If you ask me that question, the automatic reply is it's the future of TAVI. But maybe we can talk a bit about other aspects of aortic stenosis as well. I don't have any disclosures. When I think about the future of TAVI, I think there's four main components that we need to consider. The first is our patient population. The second is technological advances, particularly talking about TAVI. In terms of treatment with surgical aortic valve replacement, there haven't been any major changes in recent time. I'm not a cardiac surgeon, I admit, so maybe there's things I'm not aware of. The third aspect is novel approaches in terms of techniques and access strategies when we're performing TAVI. I'll go into that in further detail later on. I think the final aspect is how you actually go about performing the procedure, where you perform the procedure, and who's present. So I'd like to cover all of these aspects during this talk. We'll start first of all with the patient population. When I think about the patient population for TAVI, I'll start first with some demographics from Germany. We know that the population is aging. I find these graphs very, very interesting because we see back here in 1910, in Germany, there was a large number of very young people, and people weren't surviving into older age, so they were dying of other problems. When we move into the 1950s, we see that with all the revolution in healthcare, people are living much, much longer. From this graph, second from the left, we can actually see there's a big dip in the middle caused by the deaths from the World War II. Moving to 2008, we see that the numbers of people aged 50, 60, 70, 80 is increasing dramatically. And predictions out to 2060, we're going to see a lot more elderly people. And this means a lot more valvular disease, a lot more aortic stenosis. This is not a problem that's going to be going away anytime soon. If you take the population that requires intervention for their aortic valve as a whole, really the number one treatment we've had up until 15 years ago, 20 years ago, was surgical aortic valve replacement. This population, I think you can divide them, you can separate them out based on their surgical risk. So those are very low risk on the left side and those are very high risk on the right. In terms of whether you can handle those patients with a means other than surgical aortic valve replacement is based on technical feasibility. So at the top we have cases of nice symmetrical calcification in the aortic valve with good access. These patients are fairly easy to deal with. And then at the bottom we have more complex cases, bad access, bicuspid valves, valve-in-valve, small valves. So in 2001, this corner was taken on by TAVI. I apologize if you have red-green color blindness. You probably won't be able to tell what's going on here. But that top corner was, of course, Alain Cribière back in 2000 doing the first TAVI. Starting with the highest risk patients. In fact, his case was a bicuspid valve, so maybe he should be a bit further down on this list, but for the sake of my argument here. Since then, TAVI has spread steadily into patients who are at prohibitive risk or high risk for surgery, moving across this cohort, moving then into intermediate risk with the partner trial, and also with the SIR-TAVI trial. We're showing again equivalence to surgical aortic valve replacement. Moving then beyond that into more down into technical feasibility areas where these more difficult cases that previously could only be managed surgically, such as bicuspid valves, are now being managed with TAVI successfully with very good outcomes. Just looking recently at a valve-in-valve propensity matching score, we're seeing equivalent outcomes with TAVI compared to redo surgery. So really, we're encroaching more and more into the surgical territory. There are some very interesting studies that are coming out that are currently recruiting patients. The three I'd like to just mention quickly here. There's the Partner 3 trial, looking at TAVI in low-risk patients, randomized surgery versus TAVI. The second one is early TAVI, and this is treating patients before they even develop symptoms of their aortic stenosis, which is currently a key criteria. This is a very interesting question. And the final one is the TAVR Unload trial. And the aim of this is to treat people who present with heart failure and moderate aortic stenosis and see if we can prevent the deleterious effect to the LV that can occur later on, the fibrosis and the thickening. So I think this will be pushing us even further, assuming these trials end up showing good results for TAVI. This is going to be pushing us even further into the realm of surgery. So let's move on to some of the technological advances in TAVI. I do need to talk a little bit about some of the existing technology as well, so it's not all about the future of TAVI. I think you have to look at some of the past of TAVI to see where it's heading. Just looking here, we really have several generations of transcatheter heart valves that have been released over the years, starting with the first generation valves, relatively simple but effective, good in the most straightforward cases, not quite so good in more complex anatomy, difficult, challenging access. Sapien, of course, for the balloon expandable valve, and the core valve for the self-expanding. There were some early valve types that didn't make it through, such as direct flow, which had rather disappointing results. We then move on to second generation. These really represent mostly a change in the delivery catheter and the ease with which these valves could be implanted. And then moving on to the third generation valves, the biggest change here is the introduction of an outer skirt. So that's the feature of the Sapien 3, the Evolut Pro, and also the Symetis Accurate AS, Lotus Edge. These all have a layer of pericardium on the outside of the valve, pressing into the annulus and reducing the risk of paravalvular leak. Moving beyond there, we're really at a stage now where we're starting to look at the next iteration of valves. In terms of what is up and coming, we know that there's going to be another iteration of the Sapien 3 valve coming out, probably fairly soon. We're hoping to implant the first cases in our center in a few weeks' time. The Centera valve, also from Edwards, is a novel self-expanding valve that's intraannular, which distinguishes it from a lot of the others, still allowing coronary access, hopefully, and delivered via motorized sheath. So I think these are going to be very interesting valves. Certainly with the Centera, we've seen some extremely good results from the CE mark study that we were undertaking. Very, very low rates of paravalvular leak, even in the most elderly, complex patients. If I then put on my thinking hat and imagine what's going to happen to TAVI beyond this time point, then I think we're going to see a progressive reduction in the size of sheaths needed to deliver these catheters, deliver these implants, perhaps moving even in the direction of 10 French. Are there going to be pathology-specific heart valves? Perhaps. Some of the third generation valves are extremely good in a huge range of pathologies. Sapien 3, the Evolut Pro. Waiting to see perhaps if Lotus Edge will come back onto the market and also be a promising option for bicuspid valves. But maybe we'll see some other options, such as specific treatments for aortic regurgitation. There is one valve on the market that's already heading in that direction. I'll talk about that a little bit later on. Perhaps a little bit more imaginary is, could you have perhaps personalized transcatheter heart valves? This may be more relevant, particularly in the mitral setting, where the mitral annulus is a highly variable shape. You come and have your cardiac CT first, and you get your valve 6 weeks later that's been personally fit to you. Talking about sheaths, we already have some very good sheath technology with the expandable sheaths. The Edwards E-sheath is a very popular sheath that goes in at about a 14 to 16 French size and then can expand through a split on the side of the sheath to allow the passage of the valve. Now we know that the risk to vessels is mainly through sheath and vessel size mismatch. So you're putting a big sheath into a vessel that's not big enough. And the main issue is when you're pushing the sheath or pulling it. So if you have a sheath that can go in small and come out small, this is going to be a big advantage. There are also other options on the market already available. The Terumo Solar Path sheath is one that goes in a very low profile, 13 French, can then be balloon expanded to allow passage of larger devices, and then at the end, balloon collapsed in order to withdraw it. Looking ahead, we're expecting to get our hands on the next generation of Edwards Axela sheath. This will be a 14 French sheath for delivering all of the valve sizes, right up to 29 millimeter valve size. We're hoping that this sheath, which doesn't have a split, it's stretchy material, will be able to navigate tortuosity much better, or even better than the current devices do, and allow us to treat even more patients transfemorally. There is another interesting sheath that I have seen in use, and that's the Transglide sheath. It's impossible to find a picture of it. If you have a picture, send it to me, please. You really can't find one. It's an interesting sheath that has an outer mesh that's like a sock that you deploy using a introducer initially, and through that sock you can then pass a rigid sheath with very, very low friction, so it reduces the friction between the vessel and the sheath size. It's a very interesting principle. I know that some operators are actually delivering the Symetis valve through the sock part of the sheath only without bothering to put in the larger stiff sheath. Sheathless technology, of course, is on the market as well. This is, although it's billed as sheathless, I do point out that there is a sheath that's built onto the catheter system of the core valve NVO delivery device. This does give you a true 18 French, so 18 French is the size of the hole you put in the vessel, which is a little bit better than putting in a rigid sheath. The one downside to this particular valve is if you do need to post-dilate, then you have to take everything out, leave your wire in the LV, replace the sheath into the femoral artery, and then pass a balloon through. In terms of the delivery catheters, flexibility and trackability have been improving ever since the first generation devices. We see that already with the Edwards system, the core valve with Symetis. These catheters have very little difficulty managing horizontal aortas, managing extreme tortuosity in the aorta. As long as you know how to use them correctly, that's often an important principle, you can generally manage most cases. The valve deployment and retrievability is also a major advantage of some of the more recent devices, particularly like the Evolut R and the Evolut Pro, the Lotus Edge as well. And moving beyond that, the Edwards Centera really is the only valve I'm aware of at the moment that's not yet released, but will allow single operator deployment using this motorized handle system. This is actually a very interesting procedure to perform, because you really only need one operator at the table. You can position the valve, take it out again if you're not happy with it, deploy it to the point where it's fully functioning, and then take it out again if needed. It's going to be a good advance. What could we do further with these delivery catheters? Perhaps having inbuilt cerebral protection. So you position your valve, you deploy the cerebral protection device in the aorta, deploy the valve, and then you take everything out again. Not quite sure. Maybe I'm working on some designs. So moving on to some of the novel approaches in TAVI. I'll talk first of all about access. So in our institution we have done most of these various forms of access. We, in the cardiology department, perform virtually every patient via transfemoral. Our preferred second route of choice is actually transcaval, caval aortic access. I'll talk to you a little bit about that later. I understand we're getting a talk about carotid access, which is another interesting, newer percutaneous access option. In terms of surgical access, we still have transapical. I think really the evidence is pushing us away from the using transapical and telling us that we should be managing these patients through a percutaneous approach if possible. Direct aortic is also a relatively minimally invasive strategy in good surgical hands. Cut downs, I think, belong in the history of TAVI, unless you have terrible vessels and no other way to do it. Just to say that in our institution we using the SAPIEN 3 valve, do more than 95% of our cases transfemorally. About 5% are then done by some other means, including the transcaval access. So this is transcaval access. For those who are not familiar with it, it's the setup in the cath lab. It will look exactly the same as if you're doing a transfemoral TAVI. So from the point of view of an interventionalist, this is really a very comfortable way to do it. You don't have to stand by the head. You can do the procedure under sedation as you would with your transfemoral cases. And really the positioning of everything doesn't need to change. There's no change in your cath lab. What you have to do is place a venous sheath into the right femoral vein. You then pass a catheter up into the inferior vena cava. You find a point which is based on your CT done before the procedure, where you are able to cut through using electrocautery into the aorta, pass a wire through, snare the wire and take it up into the aorta. At that point you're then able to upsize sheaths, pass a big sheath from the vein into the aorta and proceed with the rest of your TAVI as you would normally. Coming back out again, the aim is to plug the hole in the aorta. Now it sounds like a very dramatic procedure, but in fact, because of the physiology of hemodynamics within the area of the retroperitoneum and the aorta and the inferior vena cava, when you create a channel between the aorta and the inferior vena cava, blood actually flows from aorta to vena cava, from highest pressure to lowest pressure. And actually a little bit of interstitial pressure in the retroperitoneum minimizes bleeding. So the important thing is that you can then plug the hole at the end of the procedure. This is done usually using a vascular plug of some kind. I'll just run you through a quick procedure here. This first image shows dual angiography in the aorta and in the inferior vena cava. Oh, apologize. Let's try that again. The second box shows electrocautery cutting through into the aorta, at which point the coronary wire is then snared, pulled upwards. The sheath can be advanced into the aorta. The valve is deployed in the usual way. A vascular plug, in this case, this is a VSD occluder. It's pulled backwards from the aorta into the inferior vena cava. Sometimes you have to put a balloon into the aorta just to tamp it down. We've also used a Amplatz duct occluder with great success, an 8mm duct occluder. You can see there's a very nice result here with no residual shunting into the venous side and no leaking. Bicuspid valves are another area that TAVI is going to be extending into more and more. This is data that my colleague Antonio will be presenting to you a little bit later on, just showing that our bicuspid rate is increasing. We're seeing more patients over time. The red bar indicating that we're now treating about 10% of patients with bicuspid valves. The procedure itself is a little bit more challenging in terms of the anatomy, crossing, in terms of deployment of the valve, determining whether it's going to cause any issues. And these are factors I'll leave to Antonio to explain to you later. Bioprosthetic valve fracture. Valve-in-valve TAVI has become quite a standard treatment. We know now that it's probably as good as having surgical replacement. The one issue, and it's a big issue for TAVI, is in patients with small valves. So patients with small anatomy in the first place, the surgeons will do their best to put in the largest possible valve size. However, if they're not able to successfully do that, then patients are sometimes left with prosthesis mismatch at the end of the procedure. And if that is severe to begin with, when you put a TAVI in, it's only going to become worse. You do your TAVI, you still end up with very disappointing gradients. This recent technique is a step to address that. So there were two papers that came out in July describing in vitro and in vivo how to actually crack the rings of certain bioprosthetic valves. I'll just show you this video here quickly. This is actually an inflation going up to 9 atmospheres. It's difficult to see, but there's a little pop as the suture ring of the valve gives way. You're able to generate quite a bit more in terms of diameter within these valves. implant larger valve sizes, and improve gradients in these difficult-to-treat patients. I'll talk a little bit more about this later on when I present a talk to you tomorrow about valve fracture. This is just showing the break in the plastic. The actual Dacron ring around the plastic stays intact. It's been dissected away just so that you can see the plastic ring in this case. There's some other advanced techniques. These are techniques that we are hoping to use for the first time in a few weeks at the Deutsches Herzzentrum. These are specifically issues for valve-in-valve TAVI. The first is the lampoon technique. This is a technique used to incise the anterior mitral valve leaflet when there is a risk of causing LV outflow tract obstruction after placing a valve in the mitral position. So this is a problem that can prevent some people from being treated with TAVI to replace their mitral valve. Instead, they have to undergo, at the moment, high-risk redo mitral valve surgery that carries with it a very high mortality, as you know. In this procedure, a wire is cut, or a puncture is made through the anterior mitral valve leaflet using electrocautery. The wire is snared and then externalized. A loop of wire, which has a little bit of area denuded of its outer plastic coating, is then attached to electrocautery and pulled back to slice through the mitral valve leaflet. So this is just an example showing electrocautery being applied to the loop of wire. The bottom two pictures are infrared thermal imaging pictures showing that the area that's being heated up is only at the tip of the wire that has been removed of the plastic outer coating. That allows you to do a focal controlled cut of the mitral valve leaflet and allow you to place a valve with reduced risk of causing outflow tract obstruction. This picture just demonstrates what it looks like angiographically. Here is a short segment of a video just showing how it would be used in the aortic valve situation. Danny DeVere is the cardiologist who's been pushing this technique, which is based on lampoon and is called basilica. In this case, an incision is made in the old bioprosthesis, like this. The valve is then implanted, and this would be used in situations where you have a low coronary height and a high risk of occluding the coronary during a TAVI. Now, this procedure would be anticipated to cause very bad regurgitation. So usually you have to have the valve either in position ready to replace, to stabilize the patient, or at least have it ready to go very, very quickly. Talking about transcatheter heart valves for specific pathology, we already have one valve which is designed specifically for aortic regurgitation. So these are for aortic valves that have a minimal amount of calcium or no calcium at all. In that case, you can't rely on the compression and intrinsic radial force of your valve to stabilize within the annulus. In this case, you actually have to find some other way of anchoring the valve. So the Jenner valve, and in fact the J valve, which is a Chinese version of the valve, which is remarkably similar, has three rings that sit inside the aortic cusps. So the main force on a valve that's sitting in the aortic position is during diastole, when you have a difference in pressure in the aorta and the LV. So this prevents the valve from falling down into the ventricle, which is a problem with current TAVI devices. In terms of performing the procedure, we at the German Heart Center really take a view that this should become a completely standardized, replicatable procedure. We focus very heavily on pre-procedural planning, the use of multi-detector CT, using a minimalist setting. So the vast majority of our patients are done using no general anesthetic without TOE on the table. The patients are then up and eating lunch and dinner the same day. We believe that a good understanding of the anatomy makes your procedure much, much easier. So you go into a TAVI with no surprises, you know exactly what your strategy is going to be, and we do the fundamental steps are exactly the same every single time. This is just showing that we can describe our entire procedure and technique that we use for virtually every case on one sheet. I provide this short tip counter for people who are not so familiar with performing TAVI. There's obviously a lot of cardiologists who are interested in moving into this field. I think if you have somebody reading these steps out in the cath lab and ticking each box as you go, you can't miss anything major when you're doing a SAPIEN 3 implant. We've already shown that if you have a very standardized method of doing your TAVI, that you can improve outcomes for patients. This is data from my colleague Antonio showing that our pacemaker implantation rate, if I can just explain what we're looking at here. The bar chart on the left, cohort 1 represents the first 120 patients that were treated with SAPIEN 3. You notice that we have a pacemaker rate of about 18%. The reason for this, we believe, is that the valve was being implanted at the height recommended by the company, which was actually too low. It was impinging on the skirt was impinging on the left bundle, causing a high rate of pacemaker. Since that time, our aim has been to implant the valve 80% in the aorta, 20% in the LV outflow tract. And since then, in the last 180 patients from this publication series, we've reduced our pacemaker rate to under 6%. On the right side, we see that using the same strategy, we have achieved a rate of PVL of 1%. This is based on the pre-discharge echo, and this is without using echo on the table. So what's going to happen to TAVI? Is it going to move the same way that PCI did? We definitely have a decreasing incidence of major hemodynamic disturbance during the procedure. The rate of needing to put a patient onto ECMO in our institution is actually less than 1%. Major vascular complications are about 5 to 6% using the newer valves. And moving TAVI to centers without cardiothoracic surgery, I don't think, personally, my feeling is it's not completely ready for that. There's some limitations. One is that you will be spreading out the number of cases that are being done, and people will then have less hands-on experience week to week. At the moment, part of the reason we get very, very good results is that we're lucky enough to be able to do a lot of cases. In Germany, there's 80 million people. There's only 80 hospitals that do TAVI, which is exactly the same number of hospitals that have cardiothoracic surgery. I think this is a question, I suspect it will eventually move into other centers, perhaps when TAVI becomes smaller sheath sizes, even safer, more numbers so that people can have enough experience wherever they work. Now, just as a non-interventional treatment for aortic stenosis, there's certainly a lot of room for modification of disease progression and perhaps even preventing aortic stenosis in the first place. We know, though, that this is a two-step process. There's an initiation phase, which is a vascular and inflammatory phase, and this is followed by calcification. So there are certainly plenty of chemical targets that could be targeted on the left side on the initiation phase, but really once you reach the phase where you're starting to deposit calcium, the disease, as far as we're aware, seems to become fairly irreversible. Now this is a big challenge because we don't know when these patients are becoming active. We don't know when this inflammation starts. Patients will be asymptomatic and you won't be able to see on echo that there's inflammation beginning. So this will be an interesting area of basic science research in the future. So just to conclude, this is a great time to be a structural interventionalist. I'm very excited to say that. Assuming that we have reasonable long-term valve function with these TAVI heart valves, and that is still an assumption at the moment, the data is slowly accumulating, I think TAVI is likely to become the default treatment for most patients with severe symptomatic AS. We will always need good surgeons. We're going to need them for the cases that we're still not able to treat with TAVI. We're going to need them for the complications of TAVI. So it is important that we support surgical colleagues and that we work with them as a heart team. In terms of TAVI, we're going to be having more patient groups, lower risk patients, patients that were previously untreatable, unfavorable anatomy. It's going to become a less invasive and a safer procedure. Now, just as a plug for our course on the 4th of May, we have a course on advanced techniques in transcatheter valve treatment. We'll be discussing transcaval, lampoon, basilica, mitral valve and valve and ring procedures, cracking the ring and treatment of bicuspid valves. If anybody here is interested in attending, then please feel free to contact me and we can keep in touch. Thank you very much.
Thank you.